So let me just do a quick introduction. This is our Aspirational Healthcare Advisors meeting for August 25th. And we've got Jessen here from Capital RX to talk about their amazing pharmacy solution. So go ahead and take it away, Jessen.
Awesome. Perfect. Yeah. I was just saying, pharmacist by training, went to Kentucky. I was, before coming into the role for my previous role as the pharmacy director for Kentucky Medicaid, I was doing more research on specifically on the opioid epidemic, just because I think one of the things that Kentucky offered me at the time was a rich data set. So big data has been my passion from the beginning. Met the folks here at Capital. One of the things that I took away was a little bit of frustration, because what Capital was presenting in the marketplace was something that I thought the states needed, the federal government needed, and if you were a health plan operating in the government, in the regulated space is probably the best way. If you were a health plan operating in the regulated space, then what Capital was inherently offering was a solution that was going to really put away a lot of the headaches that independent pharmacists were seeing, what the marketplace was seeing, and I think from the regulation standpoint, what the regulators were seeing. Because again, my background kind of led to that. I think what ended up happening was a move, an easy move, I would say, from the public sector to the private sector for myself. But the way that I think Capital approaches how we enter the market is still very much aligned with what I think folks should be asking for, right? You're looking for transparency. You're looking to make sure that no games are being played with your prescriptions. And I think the model that Capital kind of presents itself with hits that. So Daryl, I have a deck ready to go. It's
you're welcome to share it anytime you want.
Cool. Perfect. And I will say, Capital RX as a whole is a fairly informal organization. So if anybody ever wants to stop and ask a question throughout, just please raise your hand and speak up. I'm happy to kind of address throughout. So real quick, everyone can see my screen. Is that right?
Yep. You're
Awesome.
looking good.
Awesome. So we'll just go through a few things here. Overview, alignment specifically with the marketplace, the types of clients we work with, clinical alignment, technology. I think one thing that probably isn't spoken about enough in this industry is the technology behind the industry. If you're already familiar with the medical side, some of the tech, the claims processing engines are decades old. So some of the things that we've kind of built in-house have allowed us to kind of be a little bit more of on the forefront of our offering. The results and obviously the governance, and then why we really do feel that we are good partners here. So up front, the mission here at Capital RX is to fundamentally change the way drugs are priced and how patients are cared for to create enduring social change. I think it's fair to say, obviously, if we're on this call specifically, that you all have probably seen that there is a need for a change. And you guys are obviously the leaders here doing this. What we're trying to identify for the market is the fact that the status quo doesn't have to be the status quo. I think, again, the fact that you're pushing the needle to change, to allow patients to have an understanding of what's going on in their benefit design, I think that's an important first step. I think on top of that, pushing the transparency envelope a lot more than what's been previously been allowed to do. I think this is kind of where Capital RX kind of sits right in that niche. So not to show, you don't have to read everybody on here, but this is more to show you that the folks here at Capital RX come from a variety of different backgrounds. I will say that probably the commonality between all of us is that we found a home here at Capital. A lot of folks have been in the industry much longer than I have, but they've been jaded. They worked at the big three, the Optums, the CVSs, the Express Scripts of the world. They've seen the games that they do for not just the broker community, but also for the downstream clients. And what ends up happening is the bottom line is really at the end of the day what everyone looks at. AJ Loyacano here is our CEO, and one thing that he says that always resonates with me is, not everybody needs a yacht. We can all have a boat, right? We don't need to be greedy in this world. And when we're talking about healthcare, I think there's a valuable aspect to be brought to it, in the sense that we really are looking to make sure that members are taken care of. The folks here are really much more tailored towards ensuring that our clients and their membership have everything that they need at their fingertips. So I mentioned before, I'm on the PBA side, but I should mention that we are a full service PBM. The way that we look at it, again, is when we have clients that are more downstream clients who might be reselling ourselves, or they have the functionality to do a number of things that we typically service for a fully or self-funded insurer group, self-funded employer group. We would kind of break apart that role and understand what can that group do on their own, what do we need to be able to provide, and then what are the kind of intricacies there that we need to make sure that there's either integration set up or vendor connectivity set up, just so they can have the benefit that they want. I mentioned again that a lot of health systems for us, they do have the ability to do a lot more than a typical employer group. The example I like to use is we have Subaru as one of our clients. Subaru is a true self-funded employer group. They don't have a formulary, they don't have pharmacists on staff, they don't have a call center. But we have health plans here that have their own call center and they have their own formularies. So that's a really easy way to kind of differentiate between the two sides here. Lego piece is much more illustrative. Again, we'll work with our clients depending on what their needs are. I will also add that we are not tied to any of these specific pieces. So for at any point during the relationship that a client at Capital X wants to take on their own call center, or they want to start contracting with their own pharmacies, that is something that we're happy to give right back. Again, from our perspective, we don't make it doesn't change how we operate. What ends up changing is how we structure our accounts, right? We want to make sure that you're trained on the tool. We want to make sure that, depending on how you get your contracts onboarded, we want to make sure that once it's put into our system, it operates the way that you've intended it to. So just a real easy way to look at it is it's Lego blocks. At the end of the day, we're going to get to a fully built Lego house, but it'll be a different flavor for everybody. We do have a fairly large book of business at this point. We're at a little over 2 million lives, about 2.1 million lives for 1/1/24, but the populations vary entirely. So I mentioned that we have a number of groups that are PBM. Again, the company was built on the back of the PBM business. And about 3 years ago, we started entering the PBA market. So since then, we've brought on one of our biggest clients is CDPHP down there at the bottom right. CDPHP is Capital Physicians District Health Plan. Capital District Physicians Health Plan. I'm sorry. I'm not dyslexic, but sometimes I talk too fast. Capital Physicians District Health Plan out of Albany, New York. They are a regional health plan that services both Medicare, Medicaid, and then they also have their exchange population as well as a commercial ASO book of business. They are the first group that went live with our platform to treat all their lines of business. I mentioned that because it was the first test that Capital RX actually had of could we service the Medicare population and the Medicaid population. I think to this day, we are more than happy to share with you the references that we have with CDPHP, but it was a testament to the fact that we are not a PBM that stays mid-tier. We are a PBM that's looking to service the entire industry at the end of the day. And what we want to make sure is our clients get the best out of us. So when CDPHP and Capital X began our conversations, one of the things that we've kind of started nuancing out are what do we need to get done in order for you to feel comfortable with us on 1/1. And so a number of enhancements have been made, but again, it goes back to the testament of what our technology allows us to do and really the faith that they've kind of put in with us. I'll also add, it's not on this slide, but for 1/1/24, we are going live with our now biggest client, Presbyterian Health Plan out of Albuquerque, New Mexico. I was late to this call actually because I was flying back from Albuquerque this morning. So Presbyterian Health Plan's implementation is well underway. Again, that's all lines of business. They are the biggest Medicaid managed care program in the state. And so they will have full advantage of kind of understanding what we get to do. But again, it's a entirely different flavor of what CDPHP was doing versus what Presbyterian wants. And so from our PBA book of business, the teams are much more aligned of understanding what are Presbyterian strengths and what are CDPHP's strengths as well. I mentioned before, again, we want to service the entire market. This is really just a snapshot of the fact that where we are, we really do feel like us entering this market, it's only going to show beneficial for us. So the payer segment here in this country, it varies everywhere, right? At this point in time, we've hit all of the commercial markets. We have hit our uninsured business. We do have a discount card offering. And then, of course, we have our individual plans that we work with our health plans. So again, this space has been untapped for a long time, I think, for a variety of different reasons. But the fact that we've kind of built our way up into this space over the last 6 years now really is a testament to the fact that we are looking to make sure that the systems can handle what we're looking to do. So some really quick fast facts about ourselves. We are an active group of sellers at this point. So we just closed our final groups for 1/1/24. I mentioned above 2 million lives. So looks like this one's at 2.4 million. We do have one thing that we do want to make sure you all are aware of are our NPS scores. One of the things that we always talk about, this industry gets a really bad rap, and it's fair, right? I mentioned before, a lot of us have found a home here. Our NPS score is a testament to the fact that what we've seen in other places in this industry, we're trying to make sure that our clients don't ever have to experience that again. So we do have 100% implementation satisfaction. In our eyes, that's easy to do. We have a very high client retention rate. That 0.5% that's missing there, it was a group that actually got purchased by somebody else, and so they were moving away from us anyways. But again, the NPS is what we want to make sure you see. And then, of course, kind of our brag slides here on the bottom there. It's the fact that our customer service teams get awards, our tech gets awards. We're consistently kind of pushing the envelope on our own selves. So what we're trying to make sure folks see is CapRx is not going anywhere. We're going to be there to fight with the big three, but from a perspective that we know we can be transparent and we can be fair and we can be efficient all in one process. So again, from our perspective, this is something that's kind of core to us, and we fully expect to continue to be growing at this rate. So a couple core principles for ourselves. I mentioned alignment before. Service NPS, I think, is going to kind of let you see the downstream impact of how we structure our call centers, how we structure our account teams, and then innovation. And that's really going to come from our technology perspective. So we are completely agnostic when it comes to drug pricing in this country. What we utilize at the end of the day is a pricing framework that typically is not used in most contracts. So we all know the PBM kind of sits in the middle right now. They do their own thing by contracting with their pharmacies. They get the rebates from pharma. They have their mail networks, their specialty drug networks that really drive most of the cost at the end of the day. And then they go out and they charge spread pricing on top of that. What we've kind of eliminated across the board is we do not allow this to occur. So all the bad that's been happening in this industry, what we don't want is for ourselves to be caught in that middle. So at this point in time, CapRx negotiates our network contracts on NADAC, National Average Drug Acquisition Cost. This is publicly available on CMS's website. We do not own any pharmacies, so we are not directing any drugs to be filled at our own mail order, at our own specialty pharmacy. If you own pharmacies, what we'll actually do is we'll just contract directly with your pharmacies at the rates that you would like us to contract with, because at the end of the day, those are your dollars. If you are the plan sponsor, all we're there to do is administer the benefit that you have created. So again, from our perspective, we don't have any of the games that most PBMs have been kind of touting. From the pharmaceutical manufacturer perspective, we do have in all of our contracts 100% pass-through. So one thing about that is there is no PBM in this country, unless you're one of the big three, where you're going to be able to directly contract with pharma. And get competitive rates. I should add that. The guys as big as Navitus, the guys as big as Medco or Envision, if you're familiar with Envision and Elixir, those groups with 10, 20 million lives, even they are running through a rebate aggregator. So the way we approach pharma is the exact same way as it's the way the market actually allows us to contract with pharma. So we will collect our dollars from our GPO. We run through Prime, who runs through Ascent, which is actually the largest rebate aggregator in the world. And then we will pass those dollars as we get them back to our clients. Of course, we will have minimum rebate guarantees that we can establish with clients. But really, at the end of the day, we don't want a piece of the drug cost. What we're charging our clients is a flat admin fee for the services that we provide. And as often as we can, we'll try to bundle those, just depending on the number of Lego blocks that our clients end up buying from us. So I don't want to bore you all, but are folks on the call at all familiar with kind of the drug supply chain at all?
Some are, but go
Okay.
ahead.
Yeah, awesome. I'll also add, when I was with Kentucky, I used to be faculty at the University of Kentucky. So if I'm ever speaking a little bit fast, I haven't lectured in a while. So if I'm ever speaking a little fast, please just slow me down. There are a couple ways that we look at how drugs get, right? At the end of the day, there should be really one way. What we see is pharma has a price, wholesaler has a price, pharmacy has a price to buy the drug. But then when it gets down to the end member, that price suddenly goes bazooka. We have AWP come in, we have discounts come in, we have effective rates come into play. Nobody really knows what the pharmacy is going to be charging that member until the claim is actually adjudicated. Well, there's a simple problem here, right? We know that if we go to any Walgreens or CVS or your local independent pharmacy, you know, when you buy an OTC drug, an over-the-counter product, you know what the price is. What Costco buys the drug at, what Walgreens buys the drug at, what CVS buys the drug at, there's a Tylenol rule that comes into effect. For whatever reason, this same price, this Tylenol rule just doesn't work when the PBM enters the space. So what we do is, by removing all of our conflicts, we have a model, a supply chain model, where our margin is solely on the adjudication of that claim at an admin fee level. So if a PBM, and other PBMs that do this on a spread level, what they might do is they're going to charge, they know the drug is going to be $50, but they're going to send out that $21, do my math right, $31, I think, sorry, $31 back, but they're going to keep $19 for themselves. This is spread. This is very much what the regulators in this country, this is what federal government's been pointing out. This is what state governments have been actually vocal about. And if I'm not mistaken, Daryl, in Utah, there's been a number of legislators that have actually spoken about this. But it's very much the problem here, because when you have areas of PBMs controlling what the drugs are, what the price of those drugs are, and then dictating to the pharmacies the price, you're really removing an entire market. You don't have independent pharmacists that can negotiate on their behalf. And at the end of the day, those are the ones that are taking care of a lot of the membership. You get a lot of times pharmacies that are really pushing numbers. And I think it's fair to say that when you're doing something like that, you're really taking away the human aspect of caring for a patient. And so Capital Rx's margin is the same, again, throughout, no matter how the claim is adjudicated. It's a per admin fee. So we just structure our contracts to make sure that our margin doesn't change. And again, our business has been able to grow at this. It's just this point in time, we're trying to make sure folks can see how we structure those contracts. So we refer to our model as the clearinghouse model. Others refer to a single ledger. Again, agnostic here, but I mentioned before, right? Retail claims here for us will adjudicate at the NADAC rate. There is no maximum allowable cost manipulation that occurs. So there's no AWP games that we allow our contracts to kind of manipulate on behalf of our members. And then we don't own a mailer specialty. So we do have contracts that allow us to have exclusivity relationships. So for example, today, Capital Rx contracts with Costco and Optum Rx for mail and specialty. And so depending on the client, they may choose to go with Costco or Optum Rx if they want a mail and specialty offer. Again, if you're a health system and you have your own mail facility, or you have your own specialty pharmacy and you have 340B in play, that's something that's very common in our space. And so those are items where we want our clients to take advantage of those systems. And then I mentioned before the pharma revenue, right? We 100% pass through of everything. And one of the reasons that we actually work with Prime through Ascent is we do allow our clients to audit us down to NDC 9 level of what drug provided what rebate. You're not going to get a lot of rebate aggregators that are going to be willing to share that level of detail. But for us, I think it was important for us to make sure that our clients had access to that level of detail, especially during audits.
Jason, I don't know how many more slides you have, but I wanted to make sure before we ran out of time that if anybody has any questions, they can interrupt and ask those. Let's just take a second and see, has anybody got a question that they want to ask Justin about what they already heard?
And Daryl, what I can do too is I will share this slide deck with you. I got a bunch of slides, but I'll make sure that you guys have this. And of course, feel free to follow up as well.
Okay. Well, I just wanted to make sure people, if they had a question, they could ask it. Go ahead and continue.
Gotcha. We have about 7 minutes, correct?
Yep.
Perfect. We'll rush through this. I mentioned NADAC before. It's actually a CMS. It's put up on the CMS website, publicly available, does not change very often, but it provides a fair reimbursement to these pharmacies. I think that's the biggest thing in my eyes. You don't get folks upset about the fact that they can no longer get their medications anywhere. We're trying to remove this concept of pharmacy deserts in this country, and we're trying to make this fair for all of our membership. So again, from our perspective, our national network allows us to do that. And obviously we want that to be something you all take advantage of as well. One of the biggest advantages of NADAC is the fact that it deflates. From familiar with AWP, when a contract says that you have an AWP discount and year over year, you're going to get a percent better. That really isn't doing much because AWP inherently is going up. That's a price that's set by pharma. NADAC is set by the actual pharmacies that are buying the drug. So they go back to CMS and they report their prices. And what we saw in our book of business for generic drugs, we saw 64% decrease. We're not taking advantage of that. We're giving our clients advantage of that. So inherent drugs, I look at it as logical economics, right? The more generics that enter the market, the less the drug should really cost. And so we see this happening now for our book of business. Medicaid has obviously seen this now since 2012, I believe. But again, from our perspective, this is really what's important. We're seeing something similar here happen with brands and specialty. We're still evaluating all the data, but this is the first time that we've seen such a large drop on brand name drugs and specialty drugs, especially important when these are the two types of drugs that are driving a majority of the expense on drug expenditures. I mentioned this before. Make sure we get through all these. I do want to talk a little bit about the way that we approach our clients. CapitalRx has a pharmacist on every single account. It does not matter if you are a 250 person life group. It does not matter if you are a 650,000 life group like Presbyterian Health Plan. We will make sure that you have a pharmacist that can take care of your needs as your account team. One of the reasons, I think a very easy reason to kind of think of this is the fact that these are people that are going to know your benefit inside out, and they're going to know what these drugs are doing. From a clinical perspective and from an operational perspective, they will know how the system is built for you. One of the things that we empower our pharmacists to do is to be consultative SMEs. So if they understand your business, they understand your population, they know what your population's utilization looks like. What their role is to provide you back with ideas and concepts and changes to your benefits that only help you and the member. So if they're seeing a high utilization of GLP-1s, right? They want to be able to jump in and help you with that. So just something.
Can I ask you a question on that point before we run out of time?
Yeah.
We've had different groups present to this group in the past, particularly, for example, on importation. And that importation does offer some amazing opportunities. Do you facilitate that, or do you have to go outside of CapitalRx if an employer wants to take advantage of importation? Same question relative to the grants that are available that people can sometimes apply for. Do you help coordinate that? Is that all in your, or does somebody have to go outside of that?
So importation, we take a stance of because there is so much risk of not having control of that supply chain from an insurance standpoint, we take a stance of we will not adjudicate those claims. So if our employer population, however, if you are the owner of the plan and you have a separate operation that allows that, we have no say in that. We will not touch that. Just because of how the supply chain is set up, we just wouldn't have access to, we would be put at a higher liability is probably the easiest way to say it.
Right.
So
what about grant? Like, where they go and you basically get the tax reports from the patient or the employee and access philanthropy groups to get the paid for at no cost.
Yep. So like what we patient assistance programs, Yep. So we have partnered with other folks before. So if you already have a relationship with one, we can certainly load theirs.
Hey, George.
Hey, Jeff.
Yeah.
Jeff, put your phone on mute. Thanks. Okay.
I think the one thing to mention though, Daryl, is we've actually created our own program, our own patient assistance programs. Yep. And we offer that to all of our clients. What we see is we have a much lower fee to actually administer it. But the advantage is because we're actually adjudicating the entirety of the claim and we know the benefit, we actually put clinical protocols on top of it. So we're not doing it to make sure the patient gets the drug, right? We're doing it because is this the right drug for that patient? So we'll make sure we run through all those checks before that claim ever gets adjudicated at the end of the day.
And then the last question, do you integrate with any of the pharmacogenetic groups to tie what you do in with, will the drug even be metabolized?
Yes, that's a great question. We actually just rolled out this year, I believe on 7/1, our pharmacogenomics program.
Okay.
So we partner with a group that actually sends the kits out. We will actually do the test, or obviously the swab comes out. Our partner will actually do the testing, and then we get the report along with the plan sponsor to ensure that the member is getting the drug that's appropriate for that member.
Nice.
So we actually do have an offering for that. It's completely seamless. We coordinate all of that. We have our care team that sends out the kits, walks them through it, where to mail it back. And then ideally, we're not allowing claims that shouldn't be appropriate.
And what is the price point now? That's been around for a number of years. What is it? What does that generally cost to do a pharmacogenetic test?
We're in about a $500 per case.
Okay. So it's come down from 900.
Whoa.
Yeah.
That's still way up there. But that's okay. You're doing it. So.
Yeah.
Martin's got a resource for you, it sounds like.
Martin, listen, I'll take your feedback because I think I tend to agree. Like, everybody has good ideas, but it's who's going to be footing the bill, right? And I think I hear it from you, right? Because if you don't know how that's going to work, then it's not fair for the plan sponsor or that member to put up that price point.
Yeah. Well, but they used to be $900, $1,200. So.
Oh yeah, I mean,
Yeah, I listen. I remember when I was in pharmacy school, this wasn't even a concept, or it was a budding concept. It wasn't something that was even commercially available. So certainly something.
Justin, will you put your contact information up? You might have a few more slides, but we're running out of time. I do want it to get on the recording so that people can contact you if they need to.
Yeah, you know what? I will send it over right now. I have a number of slides, but I think what might make just sense here is let me just stop here. And then I'll put my contact in the chat. Is that helpful?
Yeah, do you have a slide with it? Because the recording will pick up the slide, but it won't pick up the chat.
I don't know if I have a slide.
I can put the slide and your contact information when I send it out.
Okay.
Or when I put it up, I basically just post it now on our website that these advisors all have access to.
Okay.
So we can put on that too.
Okay. Yep. That sounds good then.
So thank you, Jessen. Sorry about the confusion. I'm glad you were able to jump on. I want everybody to hear about your solution after hearing about it at the Think 360 conference. Thanks everybody for joining us today, and we will see you on the 8th of September. And again, we'll have the same people presenting last time presenting again to answer questions because we ran out of chance to ask questions. So get your questions ready, and we'll bring them up at the next meeting. Jessen, thanks again.
Thanks everyone. I appreciate it.
thank you.
Bye.
Take care.